maybe not so quick first. So the past 20 years since Medicare approved colonoscopy, screening colonoscopy, we've done amazing things in this country and other countries. We've bent the curves for incidence of colorectal cancer and maybe mortality. And now we're kind of fine tuning that, trying to get people in, doing fit outreach. It seems to me that the low-lying fruit is still, getting people who are fit positive or in the future, either cell-free DNA positive or stool DNA positive, whatever non-invasive test that gets people in the door because they don't want to do a colonoscopy. And should those numbers be reported as a part of colorectal cancer screening? Because now your health plan, 30% of your patients did fit, and 20% of those come in to get a colonoscopy when they're positive, and yet you're reporting all of those as having been screened. And as long as programmatically they do it every year, fit positive every year, don't do a colonoscopy, you're not doing them any favors. So I guess, should we be reporting it? What are the interventions we can use, programmatically, systematically, on an individual basis to get these people in? Because I think it'll be more of an issue as we really try to fine tune this in the future.
First of all, thank you for that question, because I think this is a topic that needs more emphasis. And I think Samir would agree with me, because I think this is something that drives both of us crazy. And that's the reality that these non-invasive tests, and whether it's stool-based or these blood-based technologies that
or
are
even
coming
a flex
out,
sig with
or
two
even
polyps.
Exactly. So anything that's non-colonoscopic is a two-step screening process. And we credit health systems, private practices, primary care providers for screening an individual when they only complete that first step many of the times. And in certain clinical settings, the follow-up is as low as 18%. Only 18% of patients with an abnormal fit, and some federally qualified health centers that we work with, will get a colonoscopy after that abnormal fit. I don't consider those individuals screened, because the fit has really highlighted that they may be growing a polyp or a cancer, and we haven't investigated why that fit has turned up positive. So, many of us have advocated, actually at the state level and nationally, to change the metric or to add the metric. Changing the metric would require that second step is completed for you to say you screened that patient in your health system. Adding the metric would allow health systems to report the proportion of their patients that completed the first step, but also require them to report the proportion of patients that completed the second step. We have been able to talk about this in the media, we've published about it, but we've been unable to have policy change. And I personally think that it's going to be very hard for health systems to focus on this and to get this right unless you have policy change or mandated reporting of it as a quality measure.
So I would add to this by saying that this is a public health issue, because obviously people who have an abnormal test and they don't complete their colonoscopy, they're not really benefiting from colon cancer screening. Mm-hmm. It's also, for all of us, it's an economic issue. So there are some people who think that the new non-invasive tests are probably not going to have a big impact on colonoscopy screening. But there could be another perspective here when we think about the nuanced discussions that we're expecting primary care providers to have with their patients once there is a blood-based option that they can get up to date that day versus go for a colonoscopy. Are they really going to walk through every patient about the benefits of a colonoscopy, or are they just going to check the box and get a blood-based test? So for us as gastroenterologists, it's an economic issue too, right? If it's displacing colonoscopy volume, and the best way we can help patients and continue to provide value to the community is to make sure that we advocate really hard for this quality metric. It's going to be really important for us moving forward over the next 5 to 10 years. And the sooner we can get this in place, the better setup will be to continue our progress on reducing colon cancer incidence and mortality.
Probably especially true when some health plans require prior authorization for a colonoscopy. So thank you. Dr. Metz.
Two questions, one for Dr. Gupta about the ADR actually present in the Italian study. Second question for Dr. May, pointing out, I think you probably have the most highly motivated patient population in Southern California in the UCLA system. and how you cross correct for that. I don't get that kind of portal participation. Number one, you've got an equal portal in Kaiser, and I would submit that they don't have the same, motivation rates or response rates to the same thing. I'm not criticizing that. I'm just pointing out that we have a patient disparity.
I can go first since he just mentioned it. So I will take that as a compliment because I don't think my patient population is very motivated. Actually, when you look at the response to mailed fit outreach, you see the highest rates at around 35% that come actually out of the Kaiser system. We have mailed fit outreach at UCLA, and our rates have really hovered at the response rate about 19 to 23%. So we're moderately responsive and moderately interactive with our portal. I will agree that we have done a good job of titrating up those interventions through our electronic health system. I think the difference here, though, is the age group. I think when you when you are interacting in a portal with a 70-year-old, it's very different than interacting in a portal with a 45-year-old. And I think we actually have a lot of potential for higher engagement through the portal, through mailed outreach with our younger adult populations. That's where I think the difference is.
Okay.
And I'm sorry, could you repeat your question about
No,
the ADR?
it was just the ADR rates in the Italian study, and that, focuses actually on how many actual polyps seem to be discovered. It was just a quick look, and I thought it was rather on the low side, but I can't be sure. You've had a chance to analyze it better.
Yeah, and I'm sorry, I have that slide. I did get it from Dr. Sonor, and I didn't include it. And my recollection is that the adenoma rates were lower, and I'm hoping to see the paper because that'll get us a chance to really dig into this issue. It's going to be a really important trial for us to look at the results of.
Okay, second microphone, the gentleman from Michigan.
Thank you. Adenoma prevalence varies with age and with gender, and we have pretty set goals for our ADRs based on gender, but we don't really stratify it based on age. Although we know that as people get older, there's a higher risk of having adenomas. Why is that?
Well, to me, the argument I would make for not stratifying by age is I think it's much more important that we get very widespread measurement and dissemination of the adenoma detection rate metric. And I think it's less important what the source of the data are and how they vary by age or gender. And my recommended approach would be, let's get absolutely everyone reporting their ADR and looking at it. And I think it's with people who might not be making the threshold, where they're under 35% or under 30%. That's where we have an opportunity to do some troubleshooting. Are there real differences in case mix that might be influencing? If they're basically mainly scoping 45-year-old women, then okay, we need to take that into account as we're interpreting. But in most of those cases, what you're going to find in people with ADRs less than 30% is it's not the lower performance is not being driven by a case mix issue, that it really is an opportunity for that person to learn how to do better.
Yeah.
Yes, it's a question for both of you. We often encounter patients with a negative colonoscopy, and the family doctor continue doing yearly FIT test. So number one, the indication of FIT after colonoscopy. Number two, the incidence of positive FIT after negative colonoscopy. And the third, a positive colonoscopy, second colonoscopy after a positive FIT test.
Okay, I'm going to try to make sure we address all those scenarios. So I think the first you mentioned was the situation in which someone's had a normal colonoscopy or negative colonoscopy and then continues to get FITs.
Yes.
It's a problem. And so what's happening is that a lot of times what I find is that patients are seeing different providers and the health record isn't notating or making those providers aware that screening has been completed. So some of it is a documentation problem, particularly if patients are between health systems. I think sometimes, however, it's almost done intentionally, like this idea that you're doubly protected if you get both screening modalities. We definitely recommend against that, but recognize that it does happen. And it gets particularly tricky, as in your second scenario that you mentioned, when someone's had a normal or negative colonoscopy, gets a FIT too early, and then that FIT is positive. And we actually now have a few studies that do say that because we have a notable proportion of interval cancers, meaning cancers in individuals who are between screening interval time points, that it probably is recommended that those individuals have another colonoscopy to make sure there wasn't a missed polyp or lesion, unless you are confident that that colonoscopy was very high quality, which in many cases we cannot confirm unless you've done it yourself and you've documented all those quality indicators. So it's very tricky. I find that in the VA and also at UCLA, a lot of times we do look at the colonoscopy report. We make sure that cecal intubation has been documented. We make sure that it's an individual who has a high ADR and that the withdrawal time has been noted as at least 6 minutes. And if it's been within a year or so and the patient's not excited, we probably wouldn't repeat the colonoscopy. But if it's been longer than a year, and this is just the benchmark that we use, or if we can't confirm any of those quality metrics, then we do go ahead and repeat the colonoscopy. I'm curious, Samir, what your thoughts are on that.
The only thing I would add is we definitely need more data on this. Practically speaking, I think we need to put in our reports, no interval fit testing, no additional colon cancer screening for 10 years. And again, from a cost standpoint, it's gonna be really important. You know, anecdotally, there are people who are getting a stool DNA fit after having a colonoscopy that, you know, $500-600 test. If these blood tests come online, you know, we might have primary care clinicians just checking the box and adding it to their annual testing, and it's not going to add value. And these tests, you know, fit is one problem. The positivity is only 6%, but all of these other tests are going to have positivity rates of 10% or higher. So the volume of patients will be in this situation if we don't really emphasize that, you know, I've certified this as a low-risk colon. They do not need colon cancer screening for 10 years. You know, this is going to be an increasing problem.
Can I just say one more thing about that? Because I think this is the crux of why we're in trouble with insurance plans or coverage like UHC, United Healthcare. I mean, they tried to institute a prior authorization. We were successful in backing them up a little. We still have a long way to go because the new policy is still very restrictive. But it's because there is this perception that we overuse colonoscopy, whether it's over screening or over surveilling. So I do think that what Dr. Gupta said is critical. We do need to make sure that we are appropriately using this test so that we don't continue to have insurers come after us and regulating how we provide care for our patients.
Just 2 quick questions here. This is great. I'm just going to read it. I'm a primary care provider. Thank you for coming, primary care provider. I find supportive transportation, i.e. getting someone you know to take a person home for colonoscopy a barrier for some individuals, especially those who are FIT positive. I guess that's one question. And is there a role for CT colography as a step up in this case? So I think there's a number of ways to answer that, but somebody want to take it?
I'm getting a big times up sign, so I'll be brief. There was 2 things. There was actually one abstract at a poster at DDW that talked about supported transportation, so using rideshare, other services through hospitals. At the VA, sometimes we even house patients overnight, as particularly when they're high risk or have an abnormal fit. So I think we need more innovation and technology in that area to provide transportation and escorts. I have been in the clinical scenario where someone was inappropriate for colonoscopy, usually from a cardiopulmonary standpoint, or not so much a ride, but more clinical contraindication. And we have used CT colonography as the intermediate step. But again, you're still in that situation where the patient will likely need a colonoscopy, and that is not the recommended use. The recommended use is to go straight to traditional colonoscopy.
And I'm just going to sorry, I'm sure we had more time, we can go through it, and perhaps whoever asked the question and Dr. Menz can ask the question after. I'm just going to read one more here. This has a lot to it, but I think it's important. If there's a family history of a second-degree relative or distant relative, do we still do colonoscopies every 5 years? And I would say, what age do we do it? Because we used to do it at 45, but now we've switched to 45 for everybody. So is that a change? Also, I think really important in terms of overuse, once the patient hits 75, I'm just going to summarize it and say who should still get screened or surveilled after age 75.
Yeah, the family history of second degree, it's a mess. I don't think it's really clear. I think 2 second degree relatives is really different than 1 second degree. 1 second degree doesn't merit increased intensity of screening for them. The issue of whether we need to move back the age 40 recommendation for a first degree relative because of the changing epidemiology. We don't have data on this. We're trying to do a study on this at UC San Diego, but I'm not sure we'll have enough data to make a conclusion. The age 75 one, Dr. May and I are funded to do a study. We're hoping to start soon to look at this issue in veterans with prior polypectomy who've survived cancer-free to age 75, because we know the risks go up with age, and it's very uncertain whether doing a colonoscopy today, whether that person has enough lag time of life left to be able to benefit from that polypectomy. So I think I think a reasonable discussion is to say we really don't know if you've reached age 75 and you've been cancer-free. We really don't know whether doing another colonoscopy is going to help you or not. I think we have to be honest with patients about that, especially because we're going to be carrying the risk burden if something goes wrong during that scope. And then for people who are, have had normal colonoscopy, especially a couple normal colonoscopies, very low likelihood they're going to benefit from us repeating the test, unless you think that they've got a life expectancy beyond 85 years, which some people do. So for those people, I would consider it.
Thank you.